Next session, which is imaging in pediatric cardiomyopathy. This session is being chaired by Dr. Aparna Shamkumar. She's from CMC Vellore. And Dr. Ashita, we all heard a lecture in the pre-lunch session.
So the first talk is by Dr. Rajesh Kannan on CMR in pediatric cardiomyopathy.
Yeah, warm good afternoon to everyone. So we'll start with the post-lunch session. So since morning we are discussing about the role of cardiac MRI in different aspects, including the myocarditis and the arrhythmogenic cardiomyopathy. So the same thing, if we are coming to the pediatric case, so how that is different. So you may be doing the adult cases regularly, but suddenly if pediatric case comes, you should not say that I don't know anything about pediatric cardiomyopathy, because the many of the things are nearly same for the pediatric thing also. So I'll give you some important overview. See, what is important now? What is the significance of the cardiomyopathy in children? See, if you look at it, nearly 40% of the children who presents with a symptomatic cardiomyopathy, it's very important. So those presenting with these symptoms, and if you diagnose as a cardiomyopathy, and likely that the child will undergo either a heart transplantation or die within 2 years of the diagnosis. So that is a major impact. And other important thing is, whenever when you are talking about the pediatric cardiomyopathy, now you will be looking at the genetic testing has to be incorporated into the diagnostic algorithm. It's not just only the CT or MR or echo alone may not make a diagnosis. It's very important to have a proper genetic lab available, or you can refer to the lab where it is available for genetic testing. And another important thing is, you need not have a genetic confirmation to make a diagnosis of the genetic cardiomyopathy. So what we will do is, now we look at the family pedigree, and if there are more than one persons are involved in a family, you will strongly suspect that it can be a familial cardiomyopathy, like a familial DCM. Coming to the classification, it is nearly same like adult cardiomyopathy. Basically, we'll classify into hypertrophic cardiomyopathy, dilated cardiomyopathy. These two forms the major part of the pediatric cardiomyopathy, and other things include the arrhythmogenic cardiomyopathy, restrictive cardiomyopathy, and unclassified like a LV non-compaction. And all the cardiomyopathy can be further subdivided into whether it is familial, where there is a genetic cause, or maybe idiopathic, or non-familial. And what is important to understand is some of the genetic abnormalities like a sarcomeric protein mutation can have a different phenotypes, including say HCM and DCM. So there are not different overlap, and any type of a cardiomyopathy can present as an end-stage dilated cardiomyopathy. So there is a significant overlap, even though we classify as genetic, non-genetic, and the HCM versus the other cardiomyopathies. And when you are discussing about the cardiomyopathy, you will come across this terminology called Moses classification. So what is this? So this is nothing but the TNM staging which you are using for the tumors. So the same way, in TNM staging, you will use the T for the local tumor staging, N for the nodes, and the M for metastasis. Similarly, in Moses classification, what we are doing is, we are looking at the morphology, describing as the what type of phenotype is this HCM, DCM, or a non-compaction. Second thing is, we also look at what are the organs involved, like whether it is confined to the heart or involvement of the eye, liver. Then those are all the things will give you a clue to the diagnosis. Then you look at the genetics, whether it is autosomal dominant, recessive, or X-linked, and also look at the etiology. Like some kind, it can be a toxic or viral myocarditis. Also, some people include this as a stage of the heart failure, which is like a New York Heart Association. So to sum up something like a T3, N2, M1, so we'll call it as MH means the hypertrophic variety, OH is heart involved, autosomal dominant, and this is the type of the genetic abnormalities, and will include the NOHA class as a 2 or a 3. And when you are looking at the diagnostic workup of the pediatric cardiomyopathy, the first and foremost thing is first you draw a 3-generation pedigree to identify the other family members whoever is involved, as well as to say that what type of inheritance patterns we are dealing with. Then of course you have to do the lab test, including the creatinine, creatine kinase, enzymes, and blood lactate. Also you look at the multi-system involvement. So just by looking at the heart, you cannot make a diagnosis. Like Duchenne muscular dystrophy, that will be your diagnosis. Then you look at whether the heart is involved or not. And also ECG may have a lot of information to make a diagnosis. Then finally comes your imaging and the echo, CT, and MR. Just to give you an overview of Danon's disease, as you all know, which we have discussed in the morning, is an X-linked dominant disease. And if you look at that, not only the heart, the other important findings include the myopathies, intellectual abnormalities, as well as in the increase in the creatinine kinase. And the ECG will have a classical WPW pattern and pre-excitation, as well as arrhythmias. And if you look at the Danon's disease, usually it presents like a HCM phenotype, but also it can have a DCM phenotype. So similarly, if you look at the different abnormalities, the storage diseases, so how what are the defects involved, or what are all the organs involved, and the other ECG findings and other things are very, very critical before making a diagnosis. So I'll show you some of the typical examples of some of the pediatric cardiomyopathies. So one is the HCM, which can be broadly classified as non-familial, and one of the most common is thing is the sarcomeric HCM. Also the neuromuscular disease like the muscular dystrophies, malformation syndrome, and in infants you will look at the possible infant errors of metabolism. And the role of cardiac MR is similar to the adult patients. Most important thing will be the risk stratification, including the LGE and the T1 mapping. This is a child with the hypertrophic cardiomyopathy. You can see that there is an asymmetrical septal hypertrophy, and the LGE is showing a significant myocardial scarring, and which we can quantify similar to the adult. In this case, the having a 23% myocardial scar, which is a high risk. And what is important is, even though you are using the same thing, here the if you are looking at the absolute wall thickness, here you don't use the term whether which is a high risk, either a 15 mm, 20 mm, or like that. Instead, you'll use the Z score. So now anything more than say 4 above more standard deviation, or 6 standard deviation now will be considered as a high risk. And whereas the rest of the things are similar to the adult cardiac MR. And this is the phenotype of PRKAG2 cardiomyopathy, which we have published in Nature journal of in the scientific reports in 2020. And when we looked at the 3 different families, and nearly we got 21 patients. So we can be able to suspect based on this family pedigree, where there are multiple family members, then we suspected that it is likely to be genetic origin. And when we did complete genomic testing, it is turned out to be a PRKAG2 cardiomyopathy. And over a period of 7 years, we did a follow-up, and we have published this article. And this is characterized by asymmetrical septal hypertrophy. And this type of HCM, the LGE was relatively less as compared to the many other HCM phenotypes. Anderson-Fabry disease is very, very not typical feature, characterized by very low native T1. Remember, the 2 important conditions which will have a low T1 is, one is the Fabry, second is the hemochromatosis, iron overload. And it's also characterized by the myocardial, mid-myocardial non-ischemic scar involving the basal infralateral segments. This is a case of a Danon's disease. Again, just a 9-year-old child presenting with a massive hypertrophy. So if you look at it, the wall thickness was nearly 40 mm. So even in a child, it can get, it is almost occupying the 2/3 of the entire chest, and you can see that there is a massive hypertrophy involving the both the ventricles. It's nearly a symmetric hypertrophy. And what is characteristic is, as compared to the sarcomeric HCM, where the scar will be predominantly in the septum, here in this case, you can see that the scar in the lateral wall is more than the septum. So that is a very, very important clue. Whenever you see a massive hypertrophy in a child with the lateral wall involvement more than the septum, you think of the Danon's disease. Of course, now you have to look at the other features like an intellectual abnormalities or the ECG also. Coming to the dilated cardiomyopathy phenotype, again, the causes can be either a primary or a secondary. When you look at the secondary causes, we have a big list, including toxins, metabolic, storage diseases, and in fact, any cardiomyopathy can present as a end-stage dilated cardiomyopathy. That you have to remember. And again, when you are looking at the role of cardiac MRI, we'll be doing the Maya map, including the T1 map. And in this case, you can see that the extensive LGE. And this is a case of the Duchenne muscular dystrophy, characterized by elevated native T1 as well as the thinning and the increase in the native T1 predominantly in the lateral wall. Again, you can see that in the LGE, the lateral wall is thin, and I think you can be able to appreciate that there is a subtle non-ischemic mid-myocardial enhancement. This is not specific for this muscular dystrophy, but what is important is this is one of the common cause of death in patients with muscular dystrophy. So, if a patient is a muscular dystrophy patient having any LV dysfunction, it's very important to do a cardiac MRI to pick up these cases at a very, very early stage. And also, this is a case of again little older child presenting with a mild LV dysfunction. You can see that mild LV dilatation, and this is the one which we are talking about, the so-called the ring-like LGE. Again, there are a lot of literature. If you look at this, if you search Google for an LGE, ring-like LGE, and you'll come across a lot of articles. And it is this is the ring-like LGE. It can be either a subepicardial or a mid-myocardial LGE, where the sparing the subendocardial region and presenting with the LV dysfunction. You have a lot of different diagnoses. This is one of the latest article published in September 2023. And when you are looking at the ring-like LGE, there are multiple DDs. It's not specific for one particular disease, which includes flaminopathies, arrhythmogenic cardiomyopathy, laminopathies, as well as rarely in myocarditis also we can get this type of a picture. So what is important is it's just by looking at that ring-like pattern, you cannot make a single diagnosis. You have to look at the clinical thing, and these are the cases which will be diagnosed only by the genetic testing. Coming to the restrictive cardiomyopathy, so when we are talking about the restrictive cardiomyopathy, people always the misunderstood the HCM phenotype with the restrictive cardiomyopathy. Think that in the restrictive cardiomyopathy always the myocardial wall thickness will be increased. Yes, in many of the cases the LV wall thickness can be increased like a sarcomeric mutation or an amyloid, Fabry's, Danon and all. But there are many infiltrative disease where your wall thickness can be normal or only mildly increased, like a iron overload or a systemic sclerosis, post-RT type of restrictive cardiomyopathy. So how will you diagnose or make a suspect restrictive cardiomyopathy? This is a typical pattern where you can see that the myocardial wall thickness is nearly normal, but look at the atria. The atria are disproportionately dilated, hugely dilated atria. Here again we can see that both the atrias are really dilated. The ventricles are, the systolic function is nearly normal, but if you are doing the mitral inflow PC, then you can understand that the severe diastolic dysfunction, and also you can see that there is a dilated IVC under the hepatic vein, and in this case there are no LGE. So whenever you come across a case of the restrictive cardiomyopathy, you will include the LGE as an important part of your the cardiac MRI. Also, you will do a PC at the AV valve level, which can show the typical features of the diastolic dysfunction in the form of a very tall E wave with a very small A wave. You have to do a T2 star map to rule out a iron overload. Also, whenever needed, if you are suspecting an inflammatory cardiomyopathy, which can present like an infiltrative disease, you have to do a PET scan to pick up any mediastinal lymph nodes or an extra cardiac involvement. And this is a case which has been initially a little older child has been diagnosed as a Epstein anomaly, and here we can see that the huge atrial dilatation with a thrombus. But if you look at the right ventricle, there is a complete obliteration of the right ventricle with the dilatation of the right ventricular outflow tract there, and where there is the tricuspid valve is slightly pulled down by the endomyocardial fibrosis, and this should not be mistaken for the F10 anomaly. And very important clue will be, one is the LGE, which will show typical triple layer appearance or the triple V appearance, where characterized by the innermost layer of the hypointensity caused by the either a calcify or a thrombus, middle layer of fibrosis, and the outer layer of the normal myocardium. And if you do a CT scan, you can demonstrate the endomyocardial calcification, which is a typical of a endomyocardial fibrosis. Coming to the another important entity is the arrhythmogenic cardiomyopathy. As we all discussed in the morning, the Padua criteria is the one which is used for the diagnosis of arrhythmogenic cardiomyopathy, where you are looking at the major as well as the minor criteria, and by the advantage of the Padua criteria is, even with the MRI alone, we can diagnose the ARVC based on the two major criteria. One is the morpho-functional abnormalities in the form of a regional wall motion abnormality with the elevated RV volume and the EF, as well as if we can able to demonstrate the RVLGE, focal LGE. And this is the case which again has been referred as a possible F10 anomaly because of the huge dilated atria, and this has been mistaken for displaced tricuspid annulus. And the cardiac MRI clearly showed that the tricuspid annulus is at a normal attachment, and you can see that TR, and this is a hugely dilated right atrium under the right ventricle. And if you look at the free wall of the right ventricle, you can see that the multiple focal outpouchings with the micro aneurysms here. Again, the RVOT view clearly shows that there is a multiple focal outpouchings, and also this case the LGE showed a significant myocardial delayed enhancement on a LGE. This is a 6-year-old child presenting with the fever and the polyserositis, and cardiac MRI patients actually presents with an acute chest pain, and here it shows that there is the pericardial effusion with the mild LV dysfunction, and the native T1 values are elevated, as well as the T2 value both are elevated. Even though in this case there are no significant LGE with the typical clinical presentation and increase in the native T1 and the T2 value, we diagnosed as a case of a myocarditis. So we all know that the 2018 modified Lake Lewis criteria. So as per the criteria, just by looking at the T1 and the T2 map associated with the other findings with the appropriate clinical condition, we can make a diagnosis of myocarditis. So to sum up, how will you approach a case of the pediatric cardiomyopathy? I have taken two important entities. One is the hypertrophic cardiomyopathy, second is the dilated cardiomyopathy. It's not only the imaging which is going to give a diagnosis, but what is important is, if you look at the asymmetrical septal hypertrophy, now where the septum is disproportionately hypertrophied, then you'll think of a common things like a sarcomeric mutation. Whereas if you see a concentric hypertrophy, especially in infantile period, you think of infant errors of metabolism. And if you see an extreme marked hypertrophy, like what I showed, you think of Pompe or a Dannon's disease, where your wall thickness can be 30 mm, 40 mm with predominant involvement of the LG in the lateral wall as compared to the septum. And if you see the concentric LVH with the valve involvement, you think of the mucopolysaccharidosis. Okay, and when there is a biventricular involvement, nearly symmetric biventricular involvement is characterized by Noonan disease, especially when there is a pulmonary valve stenosis. And when a HCM patient presents with a global hypokinesia, if the initial presentation is there is significant LV dysfunction, then you'll think of a PRKG2 mutation, Dannon's disease, or end-stage sarcomeric HCM. When you are looking at the DCM, it can be the genetic variant, or if there is a posterolateral dyskinesia, then you'll think of a Duchenne or a Becker's muscular dystrophy. And when there is only mildly dilated LV with a LV dysfunction, you'll think of a myocarditis. Most of the time, the patient can recover over a period of time. So those who are interested to learn more about the CT and MR in congenital heart disease, I request to go through this textbook. Thank you. Thank you.
Thank you so much, Dr. Rajesh Kannan. So nicely explained.
Yes, yes. He is a consultant interventional pediatric cardiologist at KMCH, and he has a special interest in pediatrics and adult structural intervention, pediatric heart failure management, and cardiology. So, inviting you, sir, to share with us.
If there are any queries, I'm happy to take.
Nice talk, sir. Yes, I'm not from a radiology background, so I have some questions regarding to, for example, hypertrophic cardiomyopathy. So we worried about like sudden cardiac death. So we have certain clinical criteria where we know we have to put a device, intracardiac device, defibrillator. So if the patient has a resuscitated cardiac arrest or family history of syncope. So coming to the MRI criteria, you've given the risk factors. So you've written LGE, which shows fibrosis. So is there any like quantity of fibrosis, like amount of percentage of myocardial mass which should be fibrosis, which is a risk factor, or even if there's only a small amount of fibrosis, would you tell it's a risk factor for sudden cardiac?
Yeah. That's very, very important thing where clinicians has to understand. If you look at the most of the HCM patients, they will have some amount of scar over a period of time. So especially if it is in the RV insertion sites or only in the very minimal subtle enhancement in the septum, that is alone is not a risk factor. So higher the scar, more likely to be more risky. So in general, the cutoff value used is a 15%. So if you look at the total myocardial mass and if the scar burden is more than 15%, then it is more likely to have a the sudden cardiac death risk. That doesn't mean that 14% is means no risk, or 16% means high risk. Higher the values, it's more risky. So in general, we'll take a 15% as the cutoff, and we have a the software where you can quantify the total myocardial mass as well as the scar burden, and we can accurately say that how many percentage of myocardium is scarred.
Thank you, sir. And just one more question regarding myocarditis. So many times we have a difficulty differentiating. So you generally always say if a patient has a viral infection and then comes with a dysfunction, heart failure, it could be a post-viral myocarditis. But sometimes these patients, the viral infection might be subclinical. So in that time, we're confused if it's like a dilated cardiomyopathy due to a genetic cause, or could it be a post-viral myocarditis. So for the prognostic point of view, is it like, can you, what we used to do is do a cardiac biopsy to show if any lymphocytes or necrotic myocytes are present for the myocarditis. But the patient will already be very sick. We don't want to go invasively and do it.
Yes.
So in the case of cardiac MRI, can you very clearly differentiate between an idiopathic or genetic cause of dilated cardiomyopathy and a myocarditis? And if you can diagnose, once you diagnose as a myocarditis, how frequently do you have to do follow-up MRIs? Is it once a year or once in 6 months?
Yeah, again, a very, very relevant clinical question. So if you look at the myocarditis, as I told, as per the modified Lake Lewis criteria, you can use the T1 under the T2 map, and you can also do the LGE. In the appropriate clinical setting, and if we can able to fulfill that criteria, then we can really make a confident diagnosis of myocarditis. Having said that, there are DD, sometimes you can get a LGE in the other conditions also. But in general, if you look at the risk of the endomyocardial biopsy, especially in the sick children, it's not that good. So it's a better option will be to go for a non-invasive modalities like the cardiac MR, which we can make a diagnosis, and it can not only making the diagnosis also useful for prognosis. Like we can actually accurately quantify the LV function one. If the patient presents with a very severe LV dysfunction, it's a bad prognosis, as well as a significant extensive myocardial scar, again usually a bad prognostic sign. So now we can look at the whether it is having only a subtle enhancement versus a very dense enhancement, that also can be useful for a prognosis. And in general, you don't need a regular follow-up with the cardiac MRI. Once you make a diagnosis, then you can follow it up with the echocardiography. But if there is any doubt on follow-up, say on a 3-month or a 6-month interval, if there is any doubt or to know whether if there is an ongoing myocarditis, then you can repeat the cardiac MRI and see whether at least the myocardial edema, all those things are reversing. So that are all reversible. Whereas LGE, it may not reverse completely. It may take time. Sometimes it may persist for many years. But generally, T2 values usually come down over a period of time.
Thank you very much.
Thank you.
I think Alpa has.
spoken about T1 and T2 mapping in kids, but most of our scans we do is not with breath hold. So how do you know that that motion has not really
Yeah,
affected
so
the
we have a
values
motion
of-
correction software,
How?
so that fairly does well. The important thing is as long as we usually instruct the patient, even if we couldn't able to hold the breath, not to take a very deep breath and so to have a shallow breathing, just ask them to sleep, so that that many times work. And if you have a motion correction MOCO algorithm, then most of the time it is doing good job. So the case which I showed is you can see that the cine was not good, but actually T1 T2 map was really good.
May I request Dr. Vinod to felicitate Dr. Rajesh?